Fortunate to have Dr. Ken Ellenbogen from Virginia Commonwealth University, where he is the chair of the Division of Cardiology and the Kimmerling Professor of Medicine and Director of Cardiac Electrophysiology and Pacing. Dr. Ellenbogen earned his medical degree from Johns Hopkins, where he did his residency, and then he went on to train in cardiology at Duke University, which was one of the birthplaces of electrophysiology in the United States. He has been at VCU for a long time. He has had a stellar career. And when it comes to pacing and defibrillation, he literally wrote the book on pacing and electrophysiology, and he's become a reference in that aspect for all of us. He's also a great guy, a great mentor, and a great person to seek advice from. And today he's going to talk to us about cardiac conduction system pacing, which is really something that has revolutionized pacing as we know it, and is likely to make a change and become the standard of care for years to come. So Ken, thank you for coming. Now for questions, you can join by text. You have to text DeBakey, the word DEBAKEY, to 37607, where you can text your question, or join by paulev.com and enter DeBakey and then enter your question there. So thank you, Ken, and take it.
Thanks, Miguel. Thank you for that great introduction. It's I wish I could be there, but unfortunately I can't. And this is an amazing opportunity to speak to a large group of cardiovascular practitioners about some of the changes that have taken place in pacing. And what I'd like to do is give my own view of how we got to where we are today, which is conduction system pacing, which, as you said, has really changed the face of pacing in 2021. So here are my disclosures, of course, and it's really amazing, but I'm going to try to cover many different topics. I want to review briefly the basic hemodynamics of cardiac pacing. I will talk about the limitations of CRT pacing. I will talk a little bit about the anatomy of conduction system pacing, the anatomy of the conduction system. I will talk a little bit about the physiology of the conduction system and conduction system disease and hemodynamics of conduction system pacing. And then I'll talk about some of the practicalities of conduction system pacing, specifically the role of pacing the His bundle versus left bundle pacing. A lot to cover. And I will start off with some basic hemodynamics of cardiac pacing. Now, to really understand this subject and to be humbled by the many great people who came in front of us, I want you to go back almost 100 years ago. And Carl Wiggers published this paper in the American Journal of Physiology in 1925. And what Professor Wiggers did, what Dr. Wiggers did, is he measured the aortic pulse pressure, the aortic pressure, and the LV pressure, recordings in animals, native conduction, and then during LV apical pacing, native conduction, and LV-based pacing. The take-home message from this study almost 100 years ago was that the site of pacing can acutely compromise ventricular mechanical function. Somehow we completely forgot about this because we spent 20 years studying. This is a arterial pressure tracing taken from the cardiac cath lab at Massachusetts General Hospital. Here's a simultaneous Doppler aortic flow velocity integral during ventricular pacing in a patient with complete heart block. And you see the effect of fortuitously timed P waves on the arterial pulse, on the Doppler. And we spent 20 years obsessing about AV intervals, AV synchrony, and rate response. But it wasn't until 2003 when Mike Sweeney and I published this paper in Circulation. This was a sub-study from an NIH clinical trial called the MOST study. It was a trial of 2,000 patients with 6 sinus syndrome. They all received dual chamber pacemakers, and some were programmed VVIR, some were programmed DDDR, and at a rate of 70 beats a minute. And this shows you this sub-study, which we published, shows you what is the correlation between the percent ventricular pacing shown on the x-axis and a bad clinical outcome, either heart failure hospitalizations or atrial fibrillation. And the take-home message from this study was that it didn't matter what mode of pacing you were programmed to, DDD or VVIR. All that mattered is that if you achieved a certain pacing burden, in this particular study was 40%, your risk of heart failure hospitalizations was dramatically increased. The risk of heart failure hospitalizations you can see here, and the risk of AF was also significantly increased. So this study highlights the negative effects of ventricular pacing on heart failure and atrial fibrillation. Because of that, we and others developed pacing modes for patients with sick sinus syndrome that limited the amount of ventricular pacing, or in fact, completely avoided ventricular pacing. And these modes went by different names, but their goal was to minimize ventricular pacing because we knew ventricular pacing could be bad. So we did minimize ventricular pacing, but instead we created two new problems. We created AV dyssynchrony and RV and LV dyssynchrony at the expense of reducing ventricular pacing in patients with prolonged AV delays. So non-physiologic AV delays were possibly proarrhythmic. They led to very, very long AV intervals, sometimes 280, 300, 350 milliseconds, which were really non-physiologic. And despite that, when we actually went to look to see what kind of benefit did people get from minimizing ventricular pacing in terms of persistent AFib, in terms of all-cause hospitalization, and in terms of all-cause mortality, it turned out that we were very surprised. There was no benefit in mortality. There was no significant benefit in terms of all-cause hospitalization. The p-value was 0.09. And there's no difference in the percent of patients who ended up in permanent or persistent AFib. So all the benefits we thought we might be affording patients when we actually looked at multiple clinical trials of several thousand patients, we were actually quite disappointed. So we and others began to realize that we had been missing a disease called pacing-induced cardiomyopathy. And it was a pyramid. There were patients who had EFs of 60 or 65%, and their EFs dropped to less than 50%. But that was only the tip of the iceberg, so to speak. There were patients who had EFs of 65%, and their EF dropped to 50 or 55%. Not below normal, but still a drop. Or they had a pre-existing cardiomyopathy, and their symptoms or EF got a little bit less. Or they were hospitalized for heart failure when they previously had not been hospitalized for heart failure. Or they had an increased brain natriuretic factor. And that incidence was actually as high as up to 20% over a 3 or 4 year period of ventricular pacing. Now, we believe, and this is a paradigm we have, that patients who have pacing-induced cardiomyopathy and left bundle branch block cardiomyopathy share certain things in common. Pacing-induced cardiomyopathy is related to the RV pacing burden. It's related to how wide the QRS is with pacing. It's related to the baseline ejection fraction. The lower it is, the lower the dose of pacing is needed to cause the cardiomyopathy. With left bundle branch block cardiomyopathy, it seems to be related to the width of the QRS duration during left bundle. The treatment for that is CRT pacing, but I will show you data on conduction system pacing. The treatment for pacing-induced cardiomyopathy is CRT or conduction system pacing, and you'll hear a lot of data about both. Now, let's talk about CRT. CRT is great. It is It has been the second revolution in cardiac pacing. This is just a summary of all the current indications. Red is class 3, orange is class 2, and green is class 1 indications for different classes of heart failure, indications for CRT. I suspect there's not a cardiologist in this room who is not knowledgeable about this. However, this is a state of the art. Regardless of whether you use hard outcome measures such as mortality or cardiovascular hospitalization, whether you look at LV remodeling, ejection fraction, LV end diastolic and/or end systolic diameter, quality of life or New York Functional Heart Class, or some composite, a clinical composite that includes clinical outcomes and some sort of remodeling data, what you see is an incidence of or a non-responder rate that goes as low as about 15%, but on average is 30%. Well, you may say Ellenbogen is just, he's just giving us selected data. Although there are a lot of studies here, most of these studies, are 5 years old, 10 years old. So this is a study we presented at HRS 2021. Less than 6 months ago. It's called the SMART MSP trial. And what I draw your attention to is 26% of patients, 26% of patients did not respond to CRT. So that is a modern trial, again, with a high non-responder rate. So there are a lot of reasons for non-response to CRT. I call them the 3 Ps. Patient selection. You pick a patient who has RV dysfunction, or, for example, they have a lot of scar in the lateral wall of their left ventricle, or suboptimal lead position. The CS lead or the LV lead is in the AIV, or it doesn't capture, or you get a nodal capture, or it's very apical, or programming problems, suboptimal, non-optimal device programming, inadequate percentage of pacing. So, in fact, biventricular pacing or CRT pacing is far more complicated than you might think. This is an elegant study done in 33 patients who are undergoing CRT, 21 with a dilated non-ischemic cardiomyopathy, 12 with an ischemic cardiomyopathy. They measured DPDT max by putting a pressure wire in the left ventricle, and they pace from multiple coronary sinus sites. The take-home message is that if you acutely measure DPDT, you may be able to pace from some sites where there is a dramatic improvement in DPDT, and other sites where there is minimal improvement, to actually some sites where there is a worsening, in fact, worsening of DPDT with LV epicardial pacing from the coronary sinus. It turns out that this acute change in DPDT was well correlated with patients' long-term outcomes and LV reverse remodeling. So perhaps when we pace from the coronary sinus, we're pacing from the wrong site. Maybe we should be pacing from the LV endocardium. And you can get there through an atrial transeptal approach, transaortic, through a ventricular transeptal approach, transapical. But the only one that's being clinically done much is either an atrial transeptal approach or wireless. I do want to point out one thing right now, and that when we pace the conduction system, we're pacing in the septum, but we're actually pacing very, very close to the LV endocardium. So perhaps the ultimate LV endocardial approach, without going into the LV endocardium and having a risk of clotting or clots, is pacing through the septum into the conduction system. But let's talk about wireless LV endocardial pacing, because that has been done through this system. This was a study of a number of patients who underwent placement of this receiver electrode, which is about the size of a dime, is placed into the LV endocardium via a transaortic approach. The LV can be mapped to find the most optimal place to leave it. And this particular device is triggered. So the patient has to have an endocardial device, either a dual chamber pacer or defibrillator or a single chamber. Once the patient is paced in the RV, it allows the battery to deliver current to an ultrasound transmitter, which transmits acoustic energy to this receiver electrode in the left ventricle. And this electrode is capable of converting the acoustic energy into electrical energy and stimulating the heart. I'll talk about the clinical response, structural remodeling, and electrical remodeling with LV endocardial pacing. Because again, I think septal pacing or pacing of the conduction system is essentially LV endocardial pacing. And in those patients, you're pacing from the most ideal location possible. So what are the results? Well, the SELECT LV study was done. This patient group had previously failed conventional CRT for one of two reasons. Either they had no venous access and they could not get a CS lead, or they were a non-responder to CRT. And you can see 85% of patients experience persistent clinical benefits at 6 months. And this is compared to other studies of CRT where the response rate varied between 50 and 70%. Remember, many of these patients were non-responders. Now, you see the baseline improvement in ejection fraction at 6 months. Almost 80+% of patients had significant improvements as shown in orange in ejection fraction. There's LV reverse remodeling with a decrease in LV end diastolic volume, as you can see here, and end systolic volume as well, and of course, you can also appreciate the mean QRS duration got shorter over time. This is a fascinating observation highlighted here in this one individual patient, and you can see baseline RV pacing, IV pacing intrinsic rhythm. You compare baseline to 6 months later, and you see here at baseline with pacing, the QRS is now narrower at 6 months. With IV pacing, the QRS is narrower, and even the intrinsic QRS is narrower at 6 months, showing that this patient had reverse electrical remodeling. So I'd like to talk about the physiology of the conduction system, because we are going to spend most of the rest of the time talking about conduction system pacing. So I want to remind you that conduction system pacing, when you think about it, when I first saw it, it's really pretty amazing. You see this electrocardiogram, 12-lead electrocardiogram. This patient has a right bundle branch block, and not a little one, a big one. The QRS duration is 160 milliseconds, okay? Here we do non-selective his bundle pacing. We're capturing the right bundle, the left bundle, and the RV. QRS goes from 160 to 110 milliseconds. So the QRS is essentially normal. And we're doing it by capturing both some of this patient's myocardium, but we're capturing the conduction system because if you look closely, you will see that there is a short isoelectric interval between every single pacing spike and the QRS. And here we just see more myocardial capture. And if we just took this patient and said, we're just going to do RV pacing only, the QRS would go from a right bundle to an IVCD that looks more left bundle-ish, but from 160 to 170 milliseconds. So it really is amazing to think that bundle branch block is not permanent. It doesn't necessarily mean fibrosis, but it can be corrected. This, to me, is the hallmark of amazing studies. Hard to believe this study was done 50 years ago. This is a study that looks at the three-dimensional electrical activation of an isolated human heart. This was not a human study. And these shaded areas represent different times of electrical activation of the human heart, normal human heart. They took 7 patients who died from various strokes, intracranial bleeds. They took their hearts, they were moved within 30 minutes of death. The electrical activity of the heart was recorded from epicardial and intramural plunge electrodes. And how did they do that? The hearts were fixed in diastole by injecting the ventricles with beeswax and adding potassium chloride to the perfusion fluid. They recorded unipolar and bipolar electrograms with their surface electrodes and plunge electrodes. And here's the most amazing part. They didn't believe the results. So they did the same thing in dogs to confirm normal electrical activation of the heart begins high on the paraseptal wall, below the attachment of the mitral valve, spreads septally, beginning on the left side of the interventricular septum and going posteriorly, paraseptally, about 1/3 from the apex to the base. So coming here and going down here. Endocardial activation of the RV is near the insertion of the anterior papillary muscle through the moderator band, of course, after the onset of the LV, and then is rapidly conducted through the left ventricle. This is the normal endocardial activation of the human heart. So this is what we want to create. Let's talk about creating it. Now, today we don't have to do plunge electrodes. We don't even have to map the heart. We can do something called non-invasive mapping, which allows a panoramic view of the ventricular activation under normal physiologic conditions or in the presence of bundle branch block. The patient puts on a 252 electrode body vest and undergoes a non-contrast CT scan where the patient's specific geometry of both ventricles are delineated, as well as the specific location of every one of those electrodes projected onto the surface of their chest and heart. The unipolar raw electrodes are then projected onto geometry through phase mapping, epicardially using the inverse problem and patient-specific geometry to come up with a epicardial ventricular activation pattern. This is what it looks like. These are 2 different patients who have left bundle branch block. And you can see their ventricular activation is greater than 150 milliseconds. They're 2 different patients. I want you to look at what happens with left bundle branch block. With left bundle branch block, there's no LV breakthrough of activation. It is delayed. There's RV breakthrough that's rapid and centrifugal and spreads across the RV free wall. LV activation is impaired either anteriorly or posteriorly or both, and the basal region of the LV is latest, okay? Now, this is a left bundle 150, a left bundle 180 milliseconds. The problem with CRT, the problem with pacing is that it is highly variable from patient to patient. This is 140 patients with heart failure, 140 patients at a wide QRS duration, anywhere from 120 to over 250 milliseconds. So incredible variability. And basically, what these patients were all mapped using Crt electroanatomic mapping system endocardially. And I want you to focus on the transeptal conduction time, because we said they have left bundle branch block, so transeptal conduction is delayed. And what you see here is this slow septal conduction, highly variable, but in the vast majority of people is delayed by about 40 to 100 milliseconds, reflects electrical separation between the right and left ventricle. This reflects electrical separation between the right and left ventricle, which we believe is responsible for the QRS notching on the electrocardiogram, which is a hallmark of left bundle branch block. hallmark of left bundle branch block. But even that is not so easy. I'm going to show you 4 patients who had body surface mapping. This patient had a left bundle branch block with a QRS of 140 milliseconds. The delay in conduction is, here's the LAD to orient you. Black refers to an area of severe conduction delay. So the conduction delay is apical, goes from the apex all the way up to the lateral base. Here's a patient who had a QRS duration of 180 milliseconds. And here you can see the conduction delay is very different. Here's a line of a severe conduction delay or in fact block. And there's inferior to anterolateral conduction delay. This number here refers to the amount of dysynchrony. And here there's combined activation from apical, inferior, and superior LV, but not nearly as much dysynchrony, QRS duration of 160 milliseconds. Here we have more dysynchrony, a QRS duration of 180 milliseconds, and there's delay in the anterior to inferior posterior conduction delay. Now, here's the patient you could refer for a CRT system. And what you see here is the non-invasive mapping actually shows this patient doesn't have very severe conduction delay. In fact, what you see here is there are multiple sites of epicardial breakthrough and delay involving the LV epicardium. And the site of latest activation can be highly, highly variable with these non-responders who have IVCDs. And there's a broad spectrum of interventricular delay between the LV relative to the RV, with some patients having no significant LV delay. And in this particular patient, you see there's this patch of RV delay here, and there's a patch of LV delay along the mitral annulus. So there's really no way CRT pacing would help this patient. So to understand why we can pace the conduction system, you have to do this study, which Rod Tung did. He did this study several years ago, and he put in catheters across the tricuspid valve to record a His bundle recording from the right side. And then he put these multipolar catheters with multiple tightly spaced electrodes on the LV septum, and then move them either anterior or posterior on the LV septum to record electrical activation from the right His, from the left His, down through the Purkinje potentials. And he concluded the left bundle branch block is more often a disease of the conduction system in the left bundle or proximal to the left bundle rather than within the left bundle. And here's just tracing that shows a person with a normal QRS. You see their His bundle recording and their left bundle recordings from the base to the apex, sequential recordings proximal to distal. This patient has a left bundle branch block. They have intact Purkinje conduction, not particularly wide, but this patient with a typically nasty looking left bundle, you see there's left intrahiscian delay. That is, there's delay or block above the side of the left bundle recordings between the right-sided His bundle and the left bundle. And so in summary, he was able to show that a majority of patients who have left bundle branch block have delay within the His bundle or in the very proximal part of the His bundle bifurcating to the left bundle. And those patients can variably be corrected with His bundle pacing, but over 90% of patients can be corrected with left bundle branch block pacing, which occurs somewhere over here. Now, this is our paradigm for treatment of CRT non-responders. Failed LV implants, conduction system pacing is a no-brainer. This is just, I won't go over this in detail. I want you to understand the anatomy of the conduction system of the heart. So these absolutely beautiful images talk about the conduction system of the heart. This is now magnified. This is an image from the UCLA McAlpine Atlas. This is cross-illumination of the membranous septum. And you see that the boundary of the AV node and the His bundle is actually not typically clearly defined. But the bundle of His, which we refer to simply as the His bundle, which you can see here, is a ventricular structure. It is located within the membranous portion of the ventricular septum. Now, this His bundle is surrounded by connective tissue from the central fibrous body before it bifurcates into the conduction system here, the right bundle. And you can see the valve leaflet here. You can see why I say the His bundle is primarily a ventricular structure as it inserts into the central fibrous body in the membranous septum. The membranous septum is formed at the conjunction of the two valve leaflet commissures on the right, the commissure between the anterior and septal leaflets on the tricuspid valve, and on the left, the commissure between the right and the non-coronary sinus of Valsalva. Surrounding the His bundle itself, there's actually not much myocardial tissue, although, of course, if you put an electrode here, because of the virtual electrode effect, you probably do capture myocardium around here. But as you know, the His bundle is a cord-like structure. There's no ventricular myocardium around here. In fact, it's very well insulated. And the major connection between the cells of the His bundle and the conduction system are these intercalated discs and then these long Purkinje potential cells. In fact, this is what the conduction system of the heart looks like. This is, the His bundle's way up here, and you see the numerous ramifications and interconnections here shown for the left bundle. This goes back over 100 years ago to the monograph written by the great Japanese anatomist Tawara, and you can see his schematized version of it, the left anterior fascicle, left posterior fascicle, and he describes something which we often call the left septal fascicle. But what the take-home message is here from this slide, this is a bovine heart, and you can see basically the septal cusp of the mitral leaflet here, the aorta here, the left bundle here. Now you can see the left bundle here, and you can see the numerous serpiginous bifurcations and variations here stained with India ink dye here. You can see what an amazing network of conduction system there exists endocardially and interseptally on the left side of the heart. So the anatomy is quite simple. The green is the His bundle, and what you can see here is the His bundle, and the red is the right bundle, and the purple is the left bundle. And you can see here's the landing zone for His bundle pacing. It's a pretty narrow landing zone here. You have to hit it somewhere either above the valve, as we do in about a third of patients, or below the valve, as we do in about 2/3 of patients. But again, it's a core-like structure, very well electric. It's a core-like structure, and you can see the blue is stained here, and this is all connective tissue. So here's myocardium, here's connective tissue here, as opposed to the left bundle, where you see myocardium, and there's a small amount of connective tissue. Again, there are multiple sites where we can pace the left bundle from, multiple areas where we can place a pacing lead, very limited area to place a pacing lead here. I want to draw your attention to not so much how the EKG can be essentially normalized with left bundle pacing. I'll show you more pictures later, but to this MRI, which shows you the interventricular septum, and you can see the lead in the septum, very proximal, close to the valve, but what you can see is the lead almost abuts into the LV endocardium, but doesn't. It stops just inside the septal tissue, shown in this cartoon here. So that's what we're going to be talking about today, conduction system pacing, in the time left from me. We'll skip this because this is from a paper I wrote about half a dozen years ago, where we talked about who should have minimal ventricular pacing, who should have CRT. This entire paradigm is gone. We put conduction system pacemakers in every patient with sinus node disease and every patient with AV block. If you get a pacemaker in our place, you get a left bundle pacing lead. So why is that? Well, here's some data from block heart failure. Patients with class 1 to 3 heart failure, EF less than 50%. primary outcome. It was a composite outcome of LV and systolic volume index, urgent care visits for heart failure or death. The entire trial was driven by events related to LV and systolic volume index. So the entire trial was driven by LV remodeling. If you pace the coronary sinus biventricular pacing, you prevent electrical remodeling due to RV apical pacing. And actually, it turns out that it decreases your risk of hospitalization by about 23% or 22%. So the same is even more true with conduction system pacing. This was a study done by my colleague Pugal Vijay Raman. It's not a randomized trial, but in a way it is a randomized trial. There were two medical centers who had different EP doctors, all within 50 miles of each other. And one medical center, the EP doctors decided 100% of pacemakers, conduction system pacing. The other medical center an hour away said 100% of pacemakers, RV apical pacing. All in the same electronic medical record, all part of Geisinger medical system. And look what happened. His bundle pacing, RV pacing, primary outcome, composite death, heart failure hospitalization, or upgrade to BiV pacing, 29% lower risk of that if you had conduction system pacing. More so if you risk stratify these patients based upon what happens if you were RV pacing more than 40%, this difference is further exaggerated. Well, not everyone agrees with us on this. This European Society of Cardiology, here are their guidelines for conduction system pacing, and they basically give it a 2A recommendation only for bailout in failed CRT. However, our AHA, ACC, HRS guidelines recommend a 2A indication, any patient who has an EF between 36 to 50% or greater than 35%, between 35 and 50%, if it is thought that they will be ventricular pacing greater than 40%, then they can get a CRT or conduction system pacemaker. So what is the data on conduction system pacing in patients who have left bundle branch block? So a small study of patients who have left bundle branch block, and instead of undergoing CRT, they underwent CSP or conduction system pacing. So let's see, 63% had non-ischemic cardiomyopathies, okay? 61 patients in this trial or in this study, observational study. And of those patients, I draw your attention to the marked improvement in their QRS duration, going from an intrinsic EKG, intrinsic QRS duration of 168 milliseconds to paced, only left bundle paced 117. And if you fuse it with their native right bundle, down to 102 milliseconds. And the pacing thresholds are absolutely fantastic. The R waves, also good as well. But you don't want to hear about that. You want to know how well these patients do. What is their LV ejection fraction? And you can see at 6 months, we had 95+% of patients, a dramatic improvement in EF. And at 12 months, that dramatic improvement in EF is maintained. What about what percent of patients are super responders, either have an improvement in EF greater than 20% or have a normal EF? And you can see at 12 months, almost 60% of patients have a 20% or greater improvement in EF, and 75% of patients normalize their EF. And you can see a lot of electrical remodeling or a lot of structural remodeling. So left bundle branch block pacing for cardiac resynchronization therapy, now series of over 300 patients, 85% success, 85% success in terms of being able to pace from the left bundle. And again, the same improvements in QRS duration, in New York Heart Functional Class, in LV ejection fraction, and LV end diastolic diameter. And you can see the improvements are most marked in people who have left bundle branch block, but seen with all patients. And this is a large group of patients with mean follow-up of 6 months. Now, there will be clinical trials. This is the first clinical trial. This is not a left bundle pacing. It is a His bundle pacing. But let's take a look. This is a trial randomizing patients to BiV CRT, okay? BiV CRT, and they were successful in 96% of patients. This was only using a His bundle technique. Success was only 72%. So there were some crossovers, but based on intention to treat, BiV pacing or His pacing, you see there is a dramatic improvement in QRS duration, New York Heart Association class, reverse remodeling, that is improvement in ejection fraction, quite striking, BiV and His CRT, and remodeling with a diminution in LV and systolic volume. So this Danish trial was just a small trial, a feasibility trial. There's a larger trial that will be underway. Hemodynamics of conduction system pacing. Boy, I'll try to get that done in a couple minutes. This is His bundle pacing compared to biventricular pacing. The particular hemodynamics they did were repetitive measurements of blood pressure, and comparing blood pressure with RV apical pacing, there was really no benefit or no effect, but the mean increase in systolic blood pressure is around 4 millimeters of mercury with conduction system pacing, very similar to what it was with BiV pacing. Now, this is a modeling study, and it looks at a model of cardiac hemodynamics in patients with left bundle branch block, and it looks at CRT pacing, and it looks at the potential of conduction system pacing to improve things. So one of the ways that conduction system pacing does improve things is by optimizing AV timing, and you get a big improvement here in terms of, in the model, improvement in stroke volume. Ventricular resynchronization, which you can get by narrowing of the QRS, and you get an improvement there. And by activating the delayed areas of the left ventricle even earlier, you get more of an improvement. So the improvement in conduction system pacing is from further reduction in LV activation time over what CRT does with ventricular resynchronization and allowing optimization of AV delay. And this is just looking at the QRS. Here's the patient as a QRS. Again, a model here. No CRT, it's 175 milliseconds. With current CRT systems, you get some decrease in the QRS duration just with LV pacing. And if the patient doesn't have asystole, then you get CRT with fusion. It's about 100, go down to 140 milliseconds. But you can do better than that by normalizing conduction, which is what we can do in many patients with conduction system pacing. This is a very, very complicated slide. It would take more than a couple of minutes to go over it, but I just want to call your attention. This is a patient with left bundle branch block. VV synchrony means resynchronizing the right and left ventricle. VV means how much is the total activation time of the left ventricle. LV total activation time is here. IV total activation time is here. And LV dispersion. And what you can see if you look closely at these numbers, excuse me, is that left bundle branch block decreases LV total activation time dramatically and VV total activation time. Very similar to His bundle pacing. This is based on computer surface mapping of this one patient where they're able to do virtually everything, conventional CRT, endocardial CRT, and you'll see that left bundle branch block pacing in many ways is like endocardial CRT. So His bundle versus left bundle pacing. Well, I'm going to end with that. With left bundle pacing, your lead is located at the proximal and deep septal region, 1 to 3 centimeters apical from the distal His bundle as seen in fluoroscopy or with contrast injections or echo or CT. You get a unipolar pace QRS morphology of right bundle delay or even block in V1, either QR, big Q, small r, RSR prime. You may record a left bundle potential, as we do in about 25 to 35% of patients. Here is a movie, and you can see a little bit of dye here. So you can see the dye flush, and right over here. See the dye flush is right here. So this is right into the LV septum. And here you can see on echo here, you can see the lead is right under the LV endocardium. So you can see it's gone through a lot of septal tissue, not going anywhere, right on the LV endocardium. In conclusion, conduction system pacing avoids desynchronization in a narrow QRS complex, but do not forget AV dysynchrony. True resynchronization, taking a wide QRS complex, left bundle more than right bundle, and probably no benefit from an IVCD. That's what you can get. True resynchronization. And you have to be humble. There's great biological variability. For conduction system pacing, you can resynchronize, recoordinate, and endo is always better than epi. For BIV, generally narrow is better. You want to normalize the QRS complex when you can. Conduction system pacing is probably ideal for QRS narrowing. And clinical trials are being planned. Left bundle pacing wins because it's easy to learn and execute, stable lead performance, workflow allows easy replacement of typical RV apical pacing and CRT. We're building evidence of the power of left bundle area pacing in lieu of RV apical pacing, or maybe even traditional CS or LV pacing. And when you develop a procedure, you can't call it successful if only a few can replicate it over the long term. That's one of the advantages of left bundle branch block pacing. It's easy to do. And with that, I'd like to thank you at Texas Hard, DeBakey, and Miguel, a good friend, a renowned electrophysiologist, for giving me an opportunity to speak at this meeting. Thank you, DeBakey Hard. Thank you, Miguel.
You know, a lot of questions come to mind when trying to find where left bundle pacing or conduction system pacing is going to fit in our clinical practice. But the first one that comes to my mind is, will there ever be a trial comparing hard endpoints between traditional CRT with traditional CRT indications compared to left bundle pacing? Because this is what we're lacking. We're lacking data to say that at least is equivalent. Many of us have left bundle pacing as a backup strategy if we struggle with the coronary sinus or whatever. But I need to know that outcomes don't matter, that I'm not doing a disservice on the patient. And the problem is industry has no incentive. For them, it's probably better to keep selling, conventional CRT tools. It's a whole line of business, a whole line of products that they have. What's your take on this?
Well, I think everything you said is 100% accurate. Our colleagues at Barcelona, Luis Montt. Mm-hmm. I think you know Luis, don't you?
Yeah.
He has is either doing or completed a small trial of conduction system pacing versus CRT. It's not going to be definitive, number one. Number two, Atul Verma has gone to the Canadian cardiovascular, the Canadian NIH. It's not NIH, obviously. He is proposing a much simpler study of RV apical to conduction system pacing. I tried to convince him that's not the study to do. I have submitted with Mihail Chelu from Houston, we've submitted a multi-center study to PCORI. It got rejected. We're resubmitting it to PCORI and also submitting it to the NIH clinical trials as a large, several thousand patient study comparing conduction system pacing to conventional CRT pacing. So that will be submitted in the next month to PCORI as a second submission, taking all their criticisms in, as a large clinical trial with quality of life and remodeling endpoints. We're submitting it less, more humbly to the NIH as, can we do this pilot trial of several hundred patients, and then if it's good, a large trial. But we're not the only people who want to do that trial. Other people, Andre Davila, who also I know is another good colleague and friend of yours, has just been funded by the Brazilian Society of Cardiology or the Brazilian NIH equivalent to do a large clinical trial. I don't recall the exact details of the study, but I think it's conduction studying pacing versus CRT. And the Danish, you saw that trial, it's a 50-patient trial. That was just a feasibility trial. They're embarking on a large prospective randomized trial of this. So the bottom line is, it's sort of like many other things we do in medicine, like the Watchman, like the Champion trial. We won't know what its role is as first-line therapy for patients, but the good news is at least there are going to be 2 or 3 trials that probably will take 3 to 5 years. So in 3 to 5 years, we should have a really definitive answer.
It's really nice because we don't really need to show superiority. We just need to show that it's equivalent, and then the expense, the cost of a simpler device, simpler tools. I think it'll make a big difference. I'm glad to see that the medical community retains the leadership to move the field independent of industry in this. I have some questions from the audience. Asking about extraction of conduction system leads. I don't have any experience myself. Do you? In extracting septal, deep septal lead?
Yeah, so there's experience with 3830s that have been in for 2, 3, 4, 5 years. Obviously, there's experience in children. This lead was developed for pediatric cardiac pacing and has been used for pediatric cardiac pacing for decades. So there is experience taking this lead out of children. It's a relatively easy lead to take out. I don't know that people have taken out of the interventricular septum, but it turns out that people have been using it for hip-bundle pacing now for a while, 5, 6, 7 years. We started in 2014 implanting these leads. So there are some leads that have been extracted. It turns out that even though we call it hip-bundle pacing, as I pointed out to you, the hip-bundle there are 3 parts to the hip bundle, but the main part is in the membranous septum, and the membranous septum is below the leaflets of the tricuspid valve. When we actually when we only put hip bundle leads in a couple of years ago, we did a study, published it in JACC, where we did CT scans on 50 consecutive patients from 3 centers that had hip bundle pacing. 2/3 of the hip bundle leads were actually right below the tricuspid valve. And we've had experience extracting those leads. Pugal Vijay Raman has had experience. They do not, at least for periods of time less than 10 years, do not seem to be problematic. But there is concern that for left bundle pacing, and if you use a big sheath, you could create a VSD.
Yeah.
So there is concern about that. And, how it isn't always so easy to take CS leads out, and that is, the one misadventure I can remember was a CS lead that tore the branch of the coronary sinus and had to be dealt with.
Someone is asking about echocardiography guided parameters to predict responders to CRT versus conduction system pacing. Have you used that?
That has been a huge disaster in the field of echo and EP. The reason it is probably because echo parameters don't tell you about echo parameters tell you about mechanical problems, and they don't tell you what's causing the mechanical problem. And the perfect example of that is that patient who had an IVCD. They had a low EF, they had a wide QRS, and they had a lot of abnormal echo parameters. But this is an electrical solution. So if you have mechanical problems, but you can't fix the electrical problem, it's not going to work.
Now, I have a question expanding the role of conduction system pacing to atrial fibrillation management. So, ablate and pace was abandoned strategy before AFib ablation came. That was ablating the AV node and putting a pacemaker on everybody with AFib, not everybody, in patients with AFib to improve quality of life based on better rate response and the regularity of the RR intervals. And of course, you trade the problems of AFib and RVR for the problems of RV pacing. But now that we can do safely pacing in the conduction system without having any detriment in the ventricular function, should we be looking at using AV node ablation and conduction system pacing in more patients with AFib?
Oh, I couldn't agree with that more. I mean, you know, how many ablations, how many AFib ablations can you do? And, you know, I just saw a patient before this meeting who is 78. He's on home oxygen. He's in AFib with a rapid ventricular response. And the question was, do you want to do an AFib ablation or you just want to pace and ablate? Yeah. That's an easy one.
Yeah.
Many elderly, although we're doing a lot more ablation in elderly patients, I'm not inclined to do 3 ablations in people in their 80s.
Yeah.
I'm inclined to, we do a simple cryoballoon, pulse field AF ablation, and if they come back with, you know, rapid AF again, I've done people who have AFib and elderly patients, and they go from 30% burden of AFib to 5 episodes a year of AFib, but they go into AFib for 2 or 3 hours. They go into AFib and they literally either pass out or they go to the emergency room every time. And then it's like, yeah, well, we could ablate you again, but you're still probably at the end of the day going to have AFib occasionally. There was a study presented at the European Society of Cardiology with people who had heart failure and AFib, and they randomized them to conduction system pacing or medical management. And the patients had, CRT or medical management. And the primary endpoint was mortality, and they actually had a benefit in terms of mortality. So heart failure and AFib, and you got them on a bunch of Coreg, and you think they're well managed, and you say, no, but I'm just going to pace and ablate them, and they actually do better.
Yeah.
So I think conduction system pacing, they do amazingly well. They come in, their QRS is 110 milliseconds. You know, they do remarkably well. And, you know, you have to have the wisdom to know when it's time to stop.
So I embraced the idea early on in 2015 when we started doing his bundle pacing, and then I had a couple of cases of increasing thresholds. The logistics of doing AV node ablation and his bundle pacing are problematic because then
absolutely.
And then but with left bundle pacing is a no-brainer because you can ablate the AV node, you're safely or far away from your lead, you're not going to compromise thresholds, and it's amazing. Anyway, this was great, and we could go on for hours. Maybe next time in person we can have you over and have a real in-person conversation. But thank you very much, Ken. Great to have you, and see you next time.
Thanks, Miguel. You take care.